I'm glad to be here. I have recently joined BCH in March, and it's a pleasure to be here, and I think it's time to have a very nice talk and discussion about how to screen for prediabetes, what is prediabetes, and what does that mean at the end of the day for you. And this is a topic that is very relevant because it's one of those diseases that we are able to stop the condition, make it reversible, and what is most important and what makes my part easier is that 90+% of the results are going to depend on what you are going to do. It all depends on what patient is willing to bring to the table, obviously advised by the doctor's experience, but definitely all of those changes depend on our patients. So what's prediabetes? Prediabetes, it's the yellow flag getting close to that red flag saying this is possibly going into diabetes. I'll explain to you a little bit about the numbers and what do we do to find out about it. But it's the most important thing, it's a reversible condition, and we're going to explain how to achieve that. And obviously here it's the yellow sign to say, be careful, this can go into diabetes. And as we know, once you have diabetes, this is considered a chronic condition, even though we are able sometimes to handle diabetes without requiring medicines. But definitely the approach and the treatment that you're going to require is way different if we're able to stop this in pre-diabetes. Once diabetic, always diabetic. Even in patients that have had a gastric bypass, bariatric surgery, they are still considered diabetic even though the numbers are normal, but we're still concerned about them. So it's very important that hopefully we can detect this early and stop the process of the disease. So what is prediabetes? Basically, for you, it's important to know that prediabetes is high blood sugar levels that are not high enough to give the diagnosis of diabetes, okay? This is a chronic condition that we can find what's going on and hopefully stop the process from getting that into diabetes. In this diagram, what I want to show you is there are three main conditions going on in prediabetes that we try to achieve control of them with what we're going to propose as treatment, so hopefully you don't go into diabetes. So what we start seeing first is going to be high glucose levels. So that's going to start a system of making your body create more insulin. So that insulin at the beginning is going to be effective to control the sugar, but as time goes by and if you still have persistent elevated sugar levels, that insulin is not going to be as effective as we wish, and the body is also going to start developing resistance to that insulin. So that if that perpetuates and we're not able to control that, most of the times prediabetes can go into diabetes. So why it's important to diagnose and to find out if you have prediabetes? And it's just because numbers are very significant, and it's important to be aware of this is a chronic and this is a public health problem. Prediabetes, it's estimated to affect 1 in 3 adults in the US. We're talking about 90 million of patients in the US. And what is more important is that 8 in 10 of these adults that have prediabetes, they are not aware that they have it. So that's why there's been some research and that we are doing screening. And so prediabetes numbers are impressive. We have 90 million people affected. 8 in 10 are not aware that they have it. And then when we check for that, is that around 5 to 10% of these patients are going to progress to diabetes. And later on, when we see why we screen and why therapy that we propose is effective, we'll see how do we get this number that says that around 5 to 10% of these patients will progress to diabetes. Now, talking about diabetes, affects around 37 million of people in the US. And here again, 1 in 10 people with diabetes, they are not aware that they have it, okay? And we need to make better numbers. A lot of patients that are diagnosed with pre-diabetes are not aware that they have it, even though they have had the blood test done and it's abnormal. A lot of times physicians won't communicate with them and say, hey, your sugar is starting to be high, even though it's not completely abnormal and we don't need to start you on a medicine. Be careful, you already have pre-diabetes. So remember, 37 million have diabetes. That's every time we walk around, we're talking more around 10% of population will have diabetes. And of all these patients with diabetes, 1 in 5 are not aware that they have it. So we're talking about 20% of diabetics are not aware that they have it. So why do we have to screen? And obviously the candy cane is here, the main problem. And it's most of the times pre-diabetes and even diabetes at the beginning of the disease won't have any symptom. So this is more of looking for it, finding out if there are risk factors or if there's any need to check for you for diabetes, because most of the times when you have symptoms because of this, it's already too late and you already have diabetes and you will have advanced symptoms. The regular and common symptoms that we see are patients that are very hungry, that are very thirsty, that are urinating very frequently, and that can have unexplained weight loss, and it's not because they are following a diet or so, it's just because they are not able to use this sugar that they have because the insulin is not working the way it should. So what are the current recommendations that we have? So the United States Preventive Task Force, we have that recommendation that recently changed, and now we're screening for everyone that is 35 to 70 that has a BMI of 25 or more. That's who we recommend to screen for pre-diabetes/diabetes. There are other societies that are also very focused on diabetes. One is the American Diabetic Association, and they recommend to screen everyone that is 45 years and older, no matter your BMI, check for that. And in younger people, if the BMI is 25 or higher, or if there are significant risk factors. And one of the other questions is, I screen someone for pre-diabetes and the number is normal. Usually what's recommended is to screen every 3 years if your numbers are normal. Obviously, if there is a significant change, and we've seen that with COVID, like a lot of patients were not going to the doctor and are now more sedentary, they have gained weight. So recent weight gain, it's one of those things that should make us think, even though maybe your A1C or your sugar test was normal 1 year ago, and if you have gained 20 pounds, that's enough reason for us to check for diabetes again. So what increases the risk, or which patients that we see in the office we get concerned about that? So we already talked about BMI, right? So overweight, BMI 25 to 29.9, obesity, BMI of 30 and higher, first degree relative with type 2 diabetes. This is very important, and we see a lot of familiar association with type 2 diabetes. It's way higher related, type 2 diabetes, to family relationship rather than diabetes type 1. That is the disease that we most likely will think this is hereditary, but no, we can see more related in type 2 diabetes. There are some races and ethnicities that are more prone to have diabetes. Asian race, and actually with Asian race, the cutoff of BMI is 23 rather than 25. That's considered overweight. Hispanic Latino population is also at high risk. Black race, we can see that as well. We recommend to screen as well. Some Native American, Pacific Islander race, we also recommend to start screening, and is considered at high risk. People that are sedentary, that are not moving around without exercise, it's another high risk factor. Patients that have already other comorbidities, other diseases, high blood pressure, high cholesterol, polycystic ovarian syndrome, and other cardiovascular diseases. And history of diabetes during pregnancy is a significant risk factor that increases chances of developing diabetes in the future up to 50%. So how do we test? How do we screen for pre-diabetes and for diabetes? There are 3 tests that we have, but there are usually 2 that we use because they are easier to use and easier to order. One is a fasting glucose. Fasting is considered at least 8 hours with no food. And the other test is the hemoglobin A1C. the other test that we can do that used to be ordered more frequently, but it's inconvenient for the patient because patient has to be in the lab for a couple of hours doing this, is the glucose tolerance test. When the patient is given a certain amount of sugar, they check the sugar at the beginning, and then an hour and 2 hours after that, and based on the values, we decide if you have prediabetes or diabetes. So a normal sugar level is 99 or less. Prediabetes is when this level is between 100 and 125, and diabetes once it's 126 or higher. A1C is a test that checks your sugar for the last 90, 100 days. So this is a very good test because even if patient might not be fasting, it's going to be effective. It's not going to change if the patient says, okay, I'm going to go and see my doctor. Now I'm going to be well behaved for a week, no cakes, no sugars. This one is like children won't lie to us, so will give us a good idea of what's been happening for the last 90 days. And then the glucose tolerance test that we check the sugar for a couple of hours. If the sugar is more than 200, it's diabetes. If the values range between 140 and 199, it's prediabetes. If we have an abnormal test, usually we like to repeat the abnormal test to confirm the diagnosis. So we already know, as we said in the first slides, this is sort of the warning of saying you can go into diabetes. So remember, A1C 6.5 and higher is diabetes, but when you are in this gray zone that is 5.7 to 6.4 is what we consider prediabetes. So why do we screen? And what these couple of slides that I'm going to present to you talks about what's been done on research when we find diabetes and we're aggressive, okay? And the main goal that we found is that the more aggressive we are when you have diabetes, we prevent long-term complications. And that's sort of the main goal of trying to prevent diabetes. So I know this is a very busy slide, but the main thing here is when someone has diabetes and we're able to diagnose and treat the way they should, we can see less complications. And here, the first arrow, what I want to point to is like diabetics that are very well treated, we can prevent a lot of the complications that we see in diabetes, okay? And most of them are what we call microvascular and macrovascular complications. I'll explain to you a little bit later. But if we're able to diagnose early and treat the way they should, we can have good results. And this is impressive because this trial was done in the 90s, that they had way different treatments from what we have now, that it's significantly improved, and we can see good results, okay? And this is, again, the same with an early diagnosis and good treatment options. When you are diabetic, this is not pre-diabetes, we can see less complications that are related to diabetes. So now let's talk about, once we are able to find, unfortunately, that you have pre-diabetes, or sometimes it's called insulin resistance or glucose intolerance, what do we need to do, or what are our goals when you come and see us? So definitely the main goal is to prevent or delay the onset of diabetes. And the way to do that is preserving the way our pancreas works. The pancreas, remember, is what's going to produce the insulin, and as we checked at the beginning of the presentation, remember, when you start having high sugar numbers, the pancreas is going to start working extra. Then this extra is going to produce more insulin, and there's going to be a breaking point when this insulin is not going to be enough and is not going to work as we wish, and then we're going to have diabetes. Obviously, preventing diabetes complications, there are two main ways that doctors classify diabetes complications, and they are called microvascular and macrovascular. Macrovascular complications are related to heart attack, strokes, and what's called peripheral arterial disease, what's considered poor circulation. And microvascular complications are complications with diabetics that we see affecting eyes, what's called retinopathy, neuropathy when it affects the peripheral nerves or even the nerves that involve our organs, and also some kidney problems or nephropathy. And obviously, one important thing as well of preventing diabetes, it's a very expensive disease, and around $1 of every $4 that the U.S. will spent in care, in medical care, goes to diabetes. There's a crazy amount of money that goes towards diabetes care, and that's a cost of medicine, hospital stays, as well as patients sometimes are not able to go to work, so that really affects, we're talking about $320 billion per year. Cases of diabetes are increasing, and every time the expenses for diabetes are rising, so we're around 61% that has increased in the last 10 years. And what we see is like 60% of the cost for diabetes go towards our seniors, so that's why it's important to detect this starting at age 35 as we saw now, okay? So when we find someone with prediabetes and we say, come to the office and let's talk about it, the plan has two main components. One is diet therapy. The second part is going to be physical activity, and obviously if you are a smoker, definitely smoking cessation is going to be important. And at the end of the day, what we want to achieve with the combination of diet and increasing your physical activity is weight loss, because all the therapy in combination has shown to decrease sugar levels. It can improve your cholesterol, and by that means we can improve cardiovascular health, and by that way prevent the complications we talked earlier. So the first part of the treatment that I want to talk to you is lifestyle modifications. So there was a research done in the early 2000s called the Diabetes Prevention Program, and it involved around 3,200 patients, and what they tried to do is like, they found patients that had prediabetes, and they said, let's see how treatment can change the course of the disease. Are we going to be able to stop diabetes or no? So what they did, they randomized patients 3 ways. One was definitely just change your lifestyle. Basically was with some counseling. Every quarter will be more like check what you eat, be more active physically. Then there was an intensive lifestyle modification arm, and this one is what gave us results that we are trying to focus when we treat prediabetes. And it was an intensive change in what you do. And the main goal was trying to help you lose 7% of your weight and try to exercise 150 minutes per week. We'll go in further detail in next slides. But what's important in this intensive part of the therapy is like, it's not just the doctor. It also involves coaches, dietitians, or registered nurses. And in this trial, what they did, they were counseling patients for around 6 months, and they were doing that around 16 sessions, and they will have also communication online. So this is something that obviously the doctor, it's very important, but other resources are important. And the last slide that I'm going to show you, it's very important because there are diabetes prevention programs near your community, and there's a webpage that you can go, put your zip code, and they will tell you which facilities offer this type of programs with certified people that can help you achieve your goals. And the other arm was lifestyle changes with medication. That's called metformin. So these slides, what I want to show you is that intensive lifestyle changes make the biggest and the highest difference in preventing diabetes. So in the first slide, what I wanted to show you is who was able to lose more weight, people who were enrolled and were committed to change their life and be more active physically and change their diet. And we can see the difference here with the weight. The first analysis they did was at 3 years. So if you notice the weight loss, it's around 6-7 kilograms when they were doing significant lifestyle changes. They were able to lose weight when they were taking medicine. That's around 3-4 kilograms. And when they were the placebo, as we mentioned, is just talking to them and say, okay, let's try to lose some weight, be more active, see you in 3 months. Obviously, the change in physical activity, as expected, was higher in intensive lifestyle changes. And this is one of the most important slides that I want to show you. Is this is a follow-up after 3 years when they check these 3 therapeutic options. And lifestyle changes decrease the incidence of diabetes significantly. So in patients that were on placebo that just were told, yes, you have prediabetes, work on your lifestyle changes, there was a 30% incidence of diabetes at 3 years. That's why at the beginning of the presentation I told you around of all the diabetics patients, 5 to 10% go into diabetes, and this is what shows that at 3 years, 30%. When they were put on a medicine with very mild coaching about how to change lifestyle, 21%. And when they were significantly committed with intensive coaching, with lifestyle changes and very active, diabetes was cut in half. So this is very important. Lifestyle changes can cut the risk of going from prediabetes to diabetes 50%. So, and this is just going again, this is just for me to highlight the importance and the relevance of being committed to change this. Yes, I can prescribe a medicine that is gonna reduce your risk of diabetes 30%, but if you are committed to do this with our help, being committed to exercise and change the way you eat, we can cut this by around 58%, so that's very significant. When we're talking about exercise, maybe if you are sedentary and you gotta be exercising 30 minutes 5 times per week, it's gonna say, wow, that's crazy. But I'm gonna show you what's defined as a moderate intensity exercise. So we wanna do this for 2.5 hours per week. If you decide to go on more vigorous intensity, 75 minutes per week, it's okay. And obviously, if you can add a couple of days doing some weights to do more resistance, that's okay. But we wanna focus more in the aerobic exercise. So when we talk about moderate intensity exercise, the easier way to find out if you are clueless of what type of activity I'm doing is if when you're exercising, you're able to talk, but obviously not sing during the full activity, this is a moderate intensity exercise. If you can barely say few words, or you're very out of shape, or this is very vigorous exercise. So examples of moderate intensity exercise, and this is something that I tell to my patients when I talk to them and they are not exercising, they're being very sedentary, is like, I don't want you to start running a marathon today. Really going on a treadmill, 2.5 miles per hour, is just really walking. And this is one of those things that we really need to encourage patients. Just start being active. Walking is sort of the best activities you can start doing, and 2.5 miles per hour, unless you have significant joint conditions, arthritis, or you are very frail, then there's gonna be some limitation there. But if you're able to move around, going 2.5 miles per hour, it's okay. And maybe if you cannot achieve 30 minutes the first week, it's okay. But what I want patients to try to do is like, try 5 minutes, and if you are able to do that, why not go to 10 minutes or so. The idea is of moving more every time rather than just being very passive. And I'm glad that now BCH has this new campaign of being active during the next month, where you can go and register your activity and then have opportunity to win prizes, is because we know that exercise, lifestyle changes can make a big difference preventing diabetes, cardiovascular disease, and other conditions. And then when we talk about vigorous exercise, then this is people that are in more shape. So this now it starts being running, swimming, doing bicycle more than 10 miles per hour, jumping rope, kickboxing. So these are activities that is once you are in more shape or you've been active physically, and now that you are aware maybe you have prediabetes, so you know it's like keep doing what I'm doing. And obviously the minimum that we want is 75 minutes, but obviously if you can do it more, it's welcome. Diet. So the main goal when they did the research was trying to lose around 7% of your total weight. There's no one-size-fits-all plan. We're going to talk about some diet plans and some eating patterns that patients use and that we have done research, and also a little bit of intermittent fasting, that even though it's not a diet per se, but it's a very trendy topic, so I think it's important for me to talk about it. If you follow a diet, when we do it based on the diabetes prevention program, it's called medical nutrition therapy. And that's what's going to involve a registered dietitian, and if we can have a lifestyle coach, will be wonderful. It's been shown that if you are committed to do this and to hopefully start losing 1 or 2 pounds per week, your A1C can be cut down by 2% in 3 months. Diet, what's going to do, when we talk at the beginning, it's going to help to control your sugar, control your weight, and most of the times improves blood pressure and cholesterol, and by that we'll be able to improve your cardiovascular risk. Again, reminder, and it's going to be repetitive, but lifestyle decreases the chances of going into diabetes by 58%. And they've done research, and initially was done at 3 years, but obviously all what we do here is preventing complications, not for next year, but 10, 15, 20 years, and the numbers are impressive because they can really steer preventing the developing of diabetes if we change our lifestyle. When we talk about diet, we have 3 main groups that we focus, right? Patients will talk about, we need to talk to patients about carbs, about fat, and about protein. There's no magic formula. There's always been a question of relationship of what a percentage you need to eat from carbs, from fat, from protein. Everything has to be tailored to the patient, but grossly speaking, carbs, we're aiming to eat around 45% of your energy coming from carbs. Protein, we want to hopefully achieve around 25-30%, and the remainder of fat. And remember, even though we do this combination with some other diets that we're seeing more frequently, it's also important to consider calorie amount, and that's try to focus and hopefully get you in a calorie deficit and you start losing weight. And something that is very important that we've seen that helps with weight loss, improving sugar and cholesterol is increased fiber in your diet, and that can be part of the carbs. So, carbohydrates, we're talking about sugars. 2 main types of thinking about carbohydrates are carbohydrates that are processed, very easily absorbed by the body, that have added sugars, or carbohydrates that come with the starches, right? That they are processed first by our body and then we absorb them. And obviously with carbohydrates, if we think there are 2 main groups, and that's why I have this picture, think about an apple and think about soda. So even though both can have carbohydrates, obviously they won't have the same amount. The carbs in an apple, obviously they have sugar, but it has fiber, it has vitamins, it has minerals and other components that are very important. And when we say fiber, fiber is a carb, but it's not absorbed by the body. So maybe when you go to the grocery store and read labels, you can see total carbs and you can see also the amount of fiber. So remember, that amount of fiber that is carbs is not absorbed by the body, but it has a lot of benefits to our body. So remember, in order to get that load of sugar that you're going to have with soda and cookies, you will need tons of apples. Another way to think about carbs, it's simple versus complex carbs. We want to achieve or want to push more complex carbs in our diet rather than simple carbs. Here is a list, but obviously think about simple carbs: white rice, pasta, white bread, cakes, candy. And complex carbs, we're talking more about whole wheat bread, fruit, lentils, beans, sweet potatoes. There are other couple of ways to think about carbs that has some controversy when they've done research, but you might read about it, and it's just important to mention is the glycemic index, and they basically score carbs from a 0 to 100. The higher the number, the more sugar it has. 100 is sugar, and glycemic load is the amount of sugar that type of food is going to increase at X amount at X time when you eat it. They've done research, and what they thought that some complex foods will have low glycemic index has not been that. So there are just ways to think about it, that the nutritionist can help you with that, but it's just important for you to know that that exists, and more if you start reading or go and do your own research in the internet, know that there are 3 ways that we approach and think about carbs. Something very important, and this is something that I tell my patients is sort of the easiest way to start cutting down on carbs is cut down empty calories. And that's basically sugar-sweetened beverages. So by drinking real sugar drinks, just one per day, your risk of diabetes increases around 30%. So this is one of those easy changes that we can suggest to patients, and is if they are into soda or some juices that have added sugar, really try to think about maybe going to the zero or the diet version. There's been a lot of controversy about sugar substitutes, but what we know is that they help to cut down on the carb and calories. There's some questions about if they produce cancer or if they show that the patient is prone to sugar, so they might increase hunger. But what we know for sure is that they can help us cut down on the amount of carbs and calories and help us with some weight loss at the beginning. Long-term results we don't know at this moment. And the easy answer when patients ask me, okay, I'm going to cut down on soda, is it really safe to go now to Diet Coke or Coke Zero? The easiest option is just don't do that and go and drink water. Just a reminder, when we talk about carbs, we want to achieve around 45% of our calorie intake. When someone has diabetes, we're not talking about prediabetes, we want to achieve around 45 grams of carbs per meal. When we talk about more like low carb diets, we'll see what amount is involved there. Protein, we know the higher amount of protein in your diet, it can favor more weight loss and make your A1C better. So as we said at the beginning, 15 to 30% of your calorie intake from protein is great. Remember, carbs and protein will give you around 4 calories per 1 gram. And when we talk about fat, it gives you 9 calories. So now that we're talking about fats, again, we want to do it hopefully 20%. In the trial, when they did the diabetes prevention program, the idea was to have less than 30% of the meals being fat, of the energy per day to be fat, and that's what will help them lose some weight. 3 main ways to see fats, trans fats, that's definitely the no-no. That's the human-made fat. That's the one that has been banned by the FDA. But we were able to see on packaged foods like cakes or chocolates or deep fried food. Then we have 2 other types of fats, the unsaturated fats that are the ones that we want to promote more the use. And it's basically, think about olive oil as the highest standard of those unsaturated fats. And then in the middle, we have other type of fats that we have, for example, coconut oil that came very trendy maybe 5 years ago. A lot of people were switching into that one, but it's a fat that is not as healthy as other. And even the American Heart Association brought that to the population and said, be careful because we are seeing a lot of people with very high cholesterol numbers because of high use of coconut oil. And obviously another part of saturated fats comes from animal protein, poultry and meat, and that we're gonna, when we review the Mediterranean diet, it shows why we want to limit that maybe once or twice a week. Now, the important thing that patient wants to know is like, okay, what do I need to do? Which plan? What do I need to eat? So eating pattern is basically knowing what the patient eats, what are the preferences, and try to accommodate and do a tailored diet for the patient. There are 3 main patterns that we've done research for, and it's the Mediterranean diet, we have the low carb diet, and a low fat diet. At the end of the day, I'm going to spoil that for you. Do a plan that you can stick to so you can have results. Some of them will change the good cholesterol or the bad cholesterol, but at the end of the day, all of them improve your weight and your sugar. So Mediterranean diet, that I think is sort of the diet that is the standard of diets, has this famous pyramid of type of food that we encourage you to eat. Obviously, the main pillar is going to be fruits, vegetables, olive oil, whole grains. Then we want to make sure that protein and a little bit of the fat comes from fish and seafood. Then we're going to limit a little bit of the fat and protein from poultry, cheese, and dairy products. And what we want to try to put just less often is meats and sweets, tried hopefully once a week. What we know about the Mediterranean diet is that helps to lose weight, will improve your A1C, will lower your triglycerides, and by achieving these goals, will decrease the risk of heart disease. Vegan diet also works if you're able to stick to that, or is that something that goes or matches your plan? Do it. It can also reduce the risk of diabetes, improves your A1C, promotes weight loss, and can lower your bad cholesterol. There's questionable if it can benefit your blood pressure or your good cholesterol, but at the end of the day, we can achieve a lot of goals if you follow a vegetarian or if you want to go to vegan diet. Low-fat diet, this one again is trying to cut fats and try to get more energy from vegetables, fruits, starches, and hopefully we get more of those unsaturated fats and try to cut down the saturated fats to 10% as we were previously mentioning. And again, this can work, will reduce the risk of diabetes by improving your glucose levels and will promote weight loss. And then now the low carb diet, that I think is something that it's also very important to talk because we can see a lot of the keto diets or so. So low carb diet, as I mentioned, hopefully we can get the total energy intake less than 50%. Low carb diet is considered 26 to 45%. And very low cholesterol diet is around 26%. And here's what helps us guide like what amount of carbs you can get per meal. So if you are trying to get a diet with 1,500 calories per day, depending on how much you want to cut on carbs, but if you see here, if you want to go 40%, 50 grams per meal will get you there, 50 grams of carbs per meal. Obviously, with the dietitian, you're going to learn how to count carbs, portions, sizes. With fruits, it's important. Usually, the standard is like a small size apple, half banana. What is the biggest bang for your buck regarding carbs? Berries. You can get 1.5 cups or 1.25 cups, and that will give you a low amount of carbs. And again, with low carb diet, we just want to make sure patients don't have chronic kidney disease or pregnancy, and this is more when patients are considering doing a keto diet. This diet helps promote to reduce your A1C, improve your weight, lowers your blood pressure, and also will decrease your cardiovascular risk by increasing your good cholesterol. And intermittent fasting, as I mentioned, this is not a diet, it's more a plan of when you eat and what do you eat, and that's the important thing. There are multiple ways of approaching this. The common way of doing this is what's called 16-8. So you have an 8-hour window where you can eat and 16 hours when you don't eat. So a lot of people, if they work, what they will try to do is start eating from noon to 8 p.m. And obviously, all depends how you approach intermittent fasting. So more than going into in ketosis or changing the chemistry, what we know now from research is intermittent fasting is very comparable to a low-calorie diet. So what makes the biggest difference with intermittent fasting is the window for eating is narrow, right? So you only eat 8 hours, and if you are conscious and try to follow with intermittent fasting, doing the Mediterranean diet or a low-carb diet or a low-fat diet, you're going to achieve goals for sure. But if you just want to stick to the hour schedule and not be very conscious about your diet, you might be able to maintain your weight. And obviously, we've seen that it can promote weight loss, very comparable to a low-calorie diet, and as well can improve A1C. So at the end of the day is which dietary pattern should I stick to? One that is sustainable for you and for your lifestyle. So what we've seen, for example, keto diet, gives results pretty fast, but it's very hard for some patients to sustain. So if you think you are able to live with very low amount of carbs per day, go ahead and do it. But if you feel like you like every type of food, maybe consider doing Mediterranean diet. Something very important, increase the amount of fiber in your diet. Minimize added sugars, as we talk about drinks that have just loads of sugar. Try to do more whole grains rather than refined grains. Examples, whole grains, we're talking about brown rice, whole wheat, oatmeal. Refined grains, they've been processed, so it's like white pasta, we're talking about white rice, white bread. So those are changes that when you go and do your groceries, it's like, what should I do? If I'm gonna buy bread, try to go to whole wheat bread rather than white bread. If you do pasta, okay, maybe if you wanna do one day regular pasta, do it, but portion control. Or if you wanna do whole wheat pasta, will be better. Same tortillas. If you wanna go tortillas, go better with corn tortillas rather than flour tortillas. At the end of the day, think like eating pattern, try to go healthy. I like this phrase because it says, even like if you're in a paleo diet, you can eat hamburgers just by removing the bone, but that doesn't make that food healthy. Or again, with vegan diet, you can eat tons of lentils and sugar-sweetened beverages, and yes, you are following maybe a vegan plan, but if you are not conscious about your decisions and your choices, you can add a lot of calories even though you are sticking to a plan. Is there a role for medicine? Yes, there's a medicine that we use, metformin, that can be used trying to prevent prediabetes going into diabetes. These are the patients that we can usually fit better if there's a high BMI, if there's history of diabetes during pregnancy, younger patients, or patients that have other risk factors, right? A1Cs that are already creeping up, 6.2, getting higher when patients don't do lifestyle changes, or even if they do lifestyle changes, but maybe it was too late in the process and the A1C keeps going up. And obviously we know medications can cut down the risk of going into diabetes, but lifestyle changes perform better than the medicine. Again, remember, lifestyle changes can cut your risk of going into diabetes by 50%. And this is one resource. So if you are diagnosed with prediabetes, something that you can do, go to this link and that will open. You just will put your zip code and will tell you locations. Here, for example, near Boulder County, I checked earlier today. For example, the YMCA at Lafayette will have these classes with certified instructors that will help you to start a diabetes prevention program.
Great. Thank you, doctor. That was excellent information. We have received several questions while you were speaking, and I'm sure a few more will come in as we open the floor for questions now. So let me dive right in. Well, one frustrated guest does say, what if I'm already eating a low-carb, healthy diet, but I still cannot lose weight, and my A1C is still elevated?
So definitely we want to, something that I do when patients really bring this frustration that I understand is doing a food diary is very important, and that might be something that when you go and see your primary doc is try to make an appointment. They'll see you and say, okay, John, your A1C was 6, we are committed on doing this, and now it's 6.2. So what I will usually do, or will highly encourage patients to say, what about following up in 5 days, 3 days with my doc, and I'll bring a food diary and a diary of what I'm doing physically. Because sometimes there are some steps that we're missing and we think we're doing it right, and that might be the clue of why you are not able to achieve the weight loss and then improve your sugar. The other thing that can happen as well is if everything looks that it's working, maybe you need to start working with a certified dietitian or an RN that it's certified in nutrition and more in the diabetes prevention program. You might be already too late in the process of the disease, and maybe considering medicine might be an option. So definitely keep doing what you are doing, because even though maybe your sugar is not getting better, there are other numbers that are going to get better, and the exercise is just going to improve your quality of life.
Do statins raise A1C levels? If so, does weight loss still help if you're taking a statin?
Can you repeat the question?
Do statins raise A1C levels?
So,
if so, does weight loss still help if you're taking statins?
So statins are medicines that we use to treat cholesterol. There's been a concern of increased sugar levels, but in patients that really need cholesterol medicine, now we just don't do cholesterol medicines just because the number of the cholesterol is high. We do something that's called the cardiovascular risk score. So when your risk is high, definitely benefits of the medicine will outweigh the risk. And in prediabetes, even though you might be running high cholesterol numbers, if other risk factors, the most important one, smoking, you might not need a cholesterol medicine. But if your risk is high, definitely take the cholesterol medicine, because remember, diabetes, it's a time bomb. So you can have complications just because the sugar is high, and one of the highest risks that you have is a stroke and heart attacks. And definitely when someone needs a cholesterol medicine, is because we're trying to prevent that. So in diabetic patients, we really want to try to have them on a cholesterol medicine unless the bad cholesterol is very low. But definitely sometimes weight loss is not enough, and numbers have shown that if you need it, definitely the medicine will give you more benefit than risks. And definitely, if I have a concern with someone with pre-diabetes and cholesterol, and they need a cholesterol medicine, I go ahead and prescribe it. I'm not concerned about that causing diabetes.
Does birth control elevate A1C or glucose levels?
Not really. So we want to make sure patients don't have high blood pressure or significantly high BMI. Diabetes per se is not a contraindication for contraceptive pills. Maybe what we need to make sure is there are some patients that have polycystic ovarian syndrome, and one of the treatments, and actually number one treatment, is contraceptive pills. So sometimes they have already a baseline problem that increases the A1C and cholesterol and other levels, and that's why they are on the contraceptive pill. But per se, diabetes is not a contraindication.
This is just a positive comment that a guest said that may encourage the rest of us. It says, I've been eating low carb, moderate protein, and non-starchy vegetables. Within 2 weeks, my A1C went from 8, thanks to COVID, to 5.2.
Yeah, that's wonderful, and definitely you're telling us the clue, like, with vegetable choices, we want to go more with the greens ones, right? Rather than starchy like potatoes or sweet potatoes, we're going to go more like broccoli, cauliflower, lettuce, some carrots. So way to go, and keep doing what you're doing. And I'm glad that you were able to share this experience so you can encourage more people to follow that way.
In the chart showing the changes from 0 to 4 years, all 3 of the approaches continue to increase. Why doesn't it level out?
Because diabetes, it's a long-term disease. So it's not just going to be adding 1 plus 1. We're decreasing risk, and the way we are decreasing more risk, that's what we're seeing more benefit. So that's why it's important that, for example, now we have a lot of new medicines, but we're not going to have enough data to show prevention in 10 years or 15 years. And that's the good thing of these trials that were done in the 90s, that now we have tons of years showing that these continue to work. So now we have the tools and we have better treatments. Then obviously we hope they start comparing new treatments to older treatments and to what we've been doing regarding lifestyle changes, so we can see that we can achieve really good prevention and good numbers.
This guest comments that, let me ask this question. What is the relationship between high triglycerides and diabetes?
So diabetes is, so when I explain my patients, sometimes they have high triglycerides, but cholesterol is good. So when we check a lipid panel, they tell us your triglycerides. So this is sort of the cheap fat. It's like, well, I try to explain a lot of my patients, think about the truck driver. So he goes on the road and gets hungry, right? So he stops at the gas station and says like, I need energy, I need food. So goes down and buys the fried tacos or the hot dogs that are just spinning there for we don't know how many days. So he eats that, and it's going to give him fat, and it's going to give him sugar. And part of that fat is triglycerides, and that's fat that's going to give energy quickly, but it's also going to go and store in the liver. So he goes back on the road, and he starts driving again for 6-7 hours, and he starts getting hungry again. So he says, I'm hungry. So the liver says, like, we need to give energy to this guy. So the liver starts breaking down sugar and starts releasing triglycerides. So that's what we have found, that patients with diabetes usually run high triglycerides, and usually they go together regarding conditions that we see and treat. So usually triglycerides are not a risk factor if they are alone, unless they are very high. But in diabetics, definitely we have seen higher incidence of cardiovascular events and more related to strokes.
Does perimenopause affect women's blood sugar? I'm thin, exercise, and eat healthy. My glucose is high, 106 to 118, and my A1C is high average.
So they've been doing research about hormonal changes affecting sugar and affecting how we lose weight. So one of the things is like always been the question, like my metabolic rate will change. No regarding how your body burns, but obviously your requirements are going to change. Sometimes genetic is a component there. Sometimes you are doing the right things and you just have bad luck, right? We see that more than 60–70% of diabetics will be obese, but there's a small group that don't have obesity, so you might be part of that, and that does not mean don't keep doing what you're doing. Keep an active lifestyle, keep doing a healthy diet, but if your sugar is not getting better, rather than blaming yourself, keep working on it, and if it's time to get a medicine and the doctor feels that it's time to start a medicine, go ahead and do it.
Two questions related to the keto style eating. One is I think more of a comment, or I think you covered it, but is keto style eating considered a smart way to try to watch glycemic load and glycemic index foods? And the next question is, what are the dangers of a keto diet?
So we know that ketosis is a state of starving, right? Obviously, most of these sources are going to come from sugar. So the keto diet, what it focuses in eating a very small amount of carbs per day, it's very hard to sustain because we're used to eat carbs, right? Usually, the American diet, 50+% of the caloric intake comes from carbs. So if you're cutting that down, it's a diet that's going to give you dramatic weight loss, but it's very hard to sustain. It can give trouble because if your kidneys are failing, you start accumulating ketones, and that can give you trouble. So obviously, you're going to change your glycemic load and glycemic index because your amount of carbs per day is going to be cut down. We were talking about, we usually do 50% of the calorie intake. Now, these patients are getting very low amount of carbs. So definitely, you're going to be losing weight. The main thing that we've seen is depending how you approach keto, because some patients do keto diet, but they do a lot of butter, bacon, pork rinds or so. So we've seen crazy cholesterol numbers in keto diets, but obviously if you do a keto diet, but you are supplementing with healthy food rather than just doing the TikTok keto diet, that makes a big difference.
What kind of role do resistant carbs play in preventing diabetes? And what are resistant carbs? I've never heard of that.
I'm not familiar with the term resistant carbs. I'm more familiar with simple complex carbs. Not sure if we're referring to these, but I'm not familiar with that term.
Yeah, I'm not familiar with resistant carbs either. Okay, in the past couple of years, there's been controversy about whether prediabetes is an actual disease. What is the latest opinion on this?
So definitely, it's a condition. It's been well established, and that's why the USPSTF updated the guidelines, because we were seeing more diabetes. So definitely prediabetes is there, and the pathologic way to diabetes, it's been pretty well established, and that's just by checking high insulin levels, high sugar levels, and definitely that's a condition that thankfully is reversible. But yes, it's a condition that is very well established.
Is it true that diabetic patients can eat a dessert to replace the carb portion of a meal, as long as the protein portion is included in the meal? It won't affect the blood sugar level. What do you say about that?
Carbs, definitely trying to sell us that I'm not going to ever eat carbs, it's very hard to achieve. Sometimes when I tell my diabetic patients or more with prediabetes, a lot is gonna be about portion control. Obviously, when you are diabetic, hopefully we wanna put your 40 to 50 grams of carbs per meal. So it all depends on the portion and the type of dessert. But yes, if you wanna say, okay, I'm just gonna eat fish, like a grilled fish or grilled chicken breast, I'm gonna do broccoli that you might have a little bit of fiber there, but remember, that's not gonna be absorbed, so that's not gonna give you carbs. And then you wanna do a dessert that has 40, 50 grams, yes, you can do that. Then some people are gonna question, is that gonna increase my sugar very high or so? But at least if you are just checking on the carb amount, you're gonna be where we want you to be. So the clue might be more like portion control here. I tell a lot of my elderly patients, if you have a grandkid and he wants to go for ice cream and he wants you to go, maybe if you wanna do it once a month, go there, but don't get 2 or 3 big scoops. Get the kids' portion, and maybe if you can leave something, it's okay, because you need to live a life at the end of the day. And definitely, if you feel like you wanna do that, just be smart about the decisions you're gonna be doing the rest of the day.
Right. If I need a cortisone shot for shoulder inflammation, how much will that increase my risk of developing prediabetes?
So joint injections per se can increase the sugar levels. If you are healthy, it shouldn't increase your risk. We get more concerned with chronic users rather than an injection. I'll be more concerned if you need 3, 4, 5 injections. Definitely what's gonna be affected are the tendons and your joint per se. But if your glucose level is normal, your weight is normal, just because you're getting an injection, we won't see problem. Maybe if you are diabetic, definitely we can see you running higher sugar numbers in the next 1 or 2 weeks after an injection, but definitely it's way different a joint injection than if you go to an urgent care feeling sick and you get a parenteral shot of a steroid, then that definitely is going to change your sugar. But you shouldn't have a risk of going into prediabetes if you are healthy and a good BMI.
My first A1C was 6.1%. My doctor does not want me to lose weight. How do I eat to lower my blood sugar and still maintain my weight?
So we've seen sometimes with patients that are not obese, we want to highlight physical activity. Keep doing physical activity if you are doing or not. Make sure you can hit those 150 minutes per week. And then considering medication, it's a lot of a style. We look at the recommendations, but those are broad. Usually my style is, I'll see the patient, when we get the first number, okay, it's like you have 6.1 today. I definitely bring the option like a yes or yes, we gotta stick to a diet, we gotta stick to exercise. And then if they have a lot of risk, I say, there's an option of doing a medicine. We can start now. Obviously, an intervention with medicine can have risk of side effects. But usually I say, let's give it 3 months if you are committed to do this, and let's see how the number looks. If your number looks better, we keep doing what you're doing. If the number is worse, or you didn't work on your lifestyle changes, then maybe it's time to consider the medicine. But remember, the medicine is just an aid. It's not gonna be what's gonna fix the problem. A lot is gonna depend on what you do for that.
Right, that was one of the first questions we got. After lifestyle changes, if the A1C is still high, when do you add metformin?
Definitely depends on the doctor's style. Usually for me, depending on how high is high, but if we got a 5.6, the patient is working on that, and maybe weight is the same, or they were able to lose some weight, but now the 5.7, now it's a 6, we'll sit down and say, okay, we really gotta work on this, maybe bring you in 3 months, and if that's going 6.1, 6.2, I will definitely consider starting the medicine.
I'm going to ask you one more question. And I've never heard of sugar alcohol, but this guest asked, is it okay to use sugar alcohol such as erythritol to sweeten foods?
Yeah, that's what we were talking about. So it helps to reduce the amount of carbs. It helps you with weight loss. Long-term results, we don't know. We're talking about sugar. There's been concern about cancer, so if we use Splenda or all these artificial sweeteners, but it has shown that it will help you cut down the amount of carbs and will help you improve your sugar.
Great. All right, doctor, thank you so much for your time and expertise tonight, I think we've all learned a lot and also been reminded of just what we have to do, you know. So we have come to the end of our time, and a recording of tonight's lecture is available at bch.org/livestream. You'll receive a post-lecture survey by email, those of you who registered, and we appreciate it if you take a minute to fill this survey out for us and send it back. So again, thank you, Doctor, and thank you for joining us tonight, and have a nice night.